And just before I get started, I've been in practice for 25 years. And I think one of the keys to success in practice is hitching your wagon to companies that support you and don't just sell you advice and then walk away, which I've had experience with, unfortunately, as well. And my iTrace experience has been nothing but positive since we acquired the equipment. So I also want to tell you a little bit about my practice, because a lot of times when I go to these meetings, you feel like some of these devices are meant for high volume, large practices, multiple doctors, but I think it's more important about the outcomes than the actual volume and the kind of practice that you have. So I'm an independently owned solo practice, otherwise known nowadays as a dinosaur. We have 2 locations. I'm the sole surgeon. I have a medical retina specialist and 4 full and part-time ODs. And we have a mixed patient demographic. We have among the richest zip codes in the United States in Short Hills, New Jersey, and Clifton, which is more of a working class, and we see plenty of managed Medicaid. But we've created a niche practice, basically, of premium IOL and a dry eye practice. We do a lot of diffractive multifocals. We just got into the light adjustable, doing extended depth of focus, LRIs, a lot of femto, and we have a large emphasis on dry eye. So what I'm going to do is present a case that I found very interesting and that I found harnesses the power of the toric check technology. And then I also want to just talk a little bit about how the iTrace Prime 7.0 has elevated my practice as far as premium conversions. So, okay. So here's a case presentation. 55-year-old male presented with worsening glare while driving at night for the last 6 months. Pretty much a healthy guy at 55. And there you see his pretty wild manifest refraction. It corrected to 20/30 with some glare in both eyes. Surprisingly, he had deep anterior chambers, and he had somewhat of a cataract, and nothing going on with his posterior segment. Next slide. Actually, I guess it's working now. Okay. So the first question was, is the mild cataract the cause of his symptoms? Right? Because can you really get an accurate refraction with that much cylinder? The 4-opters only go to 6 diopters, and trial frame refractions are really not so reliable. So, before I just told this gentleman that his 1+ nucleus is the cause of his symptoms, I had to first justify both to him and to insurance, quite frankly, that we could remove his cataract. So the first thing we did was an iTrace. So here's his right eye, and you can see he's got very regular astigmatism, and the lights here are kind of bright, but I think we can still see it, right? So his, good cornea and good corneal 9.5, a DLI of 6.4, not so bad, but clearly no keratoconus and very regular bow tie astigmatism. Not so impressive in the right eye as far as, is the cataract the source of your problems? So then we did, so here again, the internal is 6.4, the cornea is 9.5, and the IS axial power is 0.17, so no signs of keratoconus. So let's look at his other eye, and that kind of iced the decision to remove his cataracts. His DLI was 3.2, and again, a healthy cornea and nothing going on with his corneal topography. So just to show you, the Chang analysis basically also just shows mainly corneal astigmatism, no other aberrations in the cornea. Very happy to see that there's no other high order aberrations or anything else. So same thing with the other eye. So my approach is informed by Dr. Warren Hill's approach, which is that I use my topographer to ascertain the axis of astigmatism, and I use my biometer to ascertain the magnitude of the astigmatism. So if we go back just for a second here, his corneal astigmatism is axis, according to the iTrace, axis 65 in the left, and and 121 in the right. Okay, so we'll skip ahead, sorry. Okay, axis is a little different on the lens star, 123 and 70, but clearly a lot of astigmatism. I also want to highlight that the left eye, even with the highest power D600 J&J lens, still is going to leave him with a diopter of astigmatism. I also use the AMO calculator because that's the lens of choice, and again, I'll go back, and the iTrace toric calculator as well, to obviously using the highest power toric lens. And again, it predicts that in the right eye, we're going to nail most of his astigmatism, hopefully, with a DIU 600 with less than half a diopter, according to AMO, and 0.5 according to the iTrace. And the left eye, however, with more corneal cylinder, shows that he's still going to have residual astigmatism about a diopter and a quarter to a diopter and a half. So here's what we did. Removed his cataract sequentially in September and October, and he was counseled that I could do, this is the best that I can do. Obviously with a +6, -6, he would be happy no matter what we did, but I instructed him that even with, especially in the United States where patients are paying out of pocket for their toric correction, that I couldn't get all of his toricity. I might be able to he would definitely be able to be corrected with glasses, and we might be able to go get any residual astigmatism either with laser vision correction or corneal relaxing incisions. We did a femto with eye-hands toric IOLs. And again, my approach is I use the iTrace axis as the axis of astigmatism. I mark it the slit lamp with a horizontal axis, and we make radial femto axis marks. If anyone's not familiar with the Catalyst by J&J, they have the ability to make these radial marks at the axis of astigmatism. So you mark the horizontal, you can see the pen marks under the scope, under the femto scope, and then you can put these marks, which are really good because they used to be arcs, and the arcs were like, I think, 10 degrees. So you would kind of have to guess at the midpoint. Now you have a 1 degree mark, and what I pretty much do in the OR is I just take a Sinski dotted with ink, and I'll put a mark at the limbus, coincident with the radial marks that the Catalyst can make. Uneventful surgery, post-out month 1, he comes in, he says, my vision's pretty good, but my left eye's blurrier than my right. It's 20/25 uncorrected in the right and 20/30 uncorrected in the left, and here's his manifest. So pretty much as predicted, he has a little residual astigmatism in the right and a lot more in the left. But this is where I find that the toric check was really helpful to me. So if you look here, and if you're not familiar with the toric check, you get a measurement again after the surgery. You need a decent enough pupil to be able to measure the internal toricity of the new IOL. But what I want to point out is a couple of things. First of all, is his corneal astigmatism went from 4.4 to 4.32. So, as Warren Hill has showed often also that most of us, your surgically induced astigmatism is essentially with a clear corneal incision of anywhere between 2.4 and 2.8 is pretty much astigmatically neutral. So that was the case here. The toric IOL power matches the corneal power, and the toric axis is 128. Intended, and the correct axis is 123. So I was off by about 5 degrees, and I could rotate 5 degrees, and I could nail the rest of his residual astigmatism. But he's happy. So I did absolutely nothing with this eye. The other eye shows very similarly. Again, the corneal astigmatism was essentially unchanged, and the toric IOL axis is at 62. The intended was 65, but according now after surgery that the optimal axis would be 69. But look down here, right? Why does he still have residual astigmatism? Some of it is certainly that 7-degree rotation to get to the proper axis would give you some correction, but it's not going to get all of it. Why? Because the toric lens power is at 4.57, but he has 5.86 in his cornea. So unless I have a DIU 7.25, which doesn't exist, I'm not going to be able to correct all of his astigmatism. But what I found really interesting also was the anticipated residual astigmatism was exactly as predicted. The AMO predicted 1.3, the iTrace 1.29, and the Barrett calculator on the LensStar predicted about a diopter that he would have left. So again, rotation would not remove all of the residual cylinder because we had maxed out on the power. It wasn't that it was off axis, it was that we had done the best we could. And yes, rotating would certainly make him maybe a little happier, but it wouldn't solve the problem. So what I did, and this is something I learned in residency, the enemy of good is perfect. If you started at +6, -6, and you're now where he was, leave well enough alone. And basically, higher power torics, especially as you all know with toric IOLs, and also when you refract people, if you're refracting someone with a quarter or half a diopter, it doesn't really matter if you're off by 5 or 10 degrees, but obviously if someone has 4 diopters of astigmatism, refractive astigmatism, they're going to notice a difference between 92 and 98 on their refraction, and the same is true with the IOL. So there's a cumulative effect, right? I mark my horizontal. Am I marking at 180 or am I marking at 178? Then that toric mark that we placed with the femto, is it really exactly at 65 or 121? Then error in aligning the lens with the toric mark. That I find with the newer model, with the latest model toric IOLs, really don't have that issue. That I can really, the lenses don't rotate, and the lens is where I leave it, and it's pretty straightforward to get it exactly where I want. But is that toric mark really the right place? And the cumulative effect, if I missed by 1 degree on marking the horizontal, 1 degree in placing the toric mark, and 1 degree in aligning the lens with a DIU 600, you're going to have residual astigmatism. But again, in this case, it's not the misalignment of the lens, it's the fact that the lens doesn't come in any higher powers. And that kind of helped in counseling this patient as well. So as I said before, managing the expectations before the surgery and explaining the limits of available technology. And this patient was sent on his way as a pretty much a happy patient. So the next thing I wanted to talk about is not really a case, but just how the iTrace Prime has increased my premium conversion rate. Because not only are outcomes important, also how we can survive in an era of decreasing reimbursements where some insurances insultingly may pay us $450 to remove a cataract in the United States anyway. And that's pretty much 2 months of a cable bill when you think about it in some places, or a cell phone bill. And to me, it's all about premium conversions. So the FACO study done by Bill Trattler and everybody in 2017, everyone's well aware of that. Most patients who come in presenting with cataracts have dry eye on some level, whether they know it or not. 60% of them were asymptomatic. And there's also the effect of dry eye and MGD on topography and biometry. Cynthia Matosin presented that basically if you treat MGD with thermal pulsation before surgery, that the 68% changed from either going from no astigmatic correction to an LRI, from an LRI to a toric, or even back the other way from a toric to an LRI, because the astigmatism went up or down in a majority of patients. So this was my old work. I pay a lot of attention to dry eye, and this was my old workflow. Patients would come in. It's really impractical to do all dry eye testing on every patient, as much as we'd like to do an iTrace on every patient that walks in the door. It's not really practical. But here's what happens, right? The patient comes, you schedule them for surgery, and you don't pay attention to dry eye. They schedule surgery, they get their medical clearance, they have all their post-op appointments set up, they have their transportation arranged, and then they come in for their pre-op measurement. And you get variable biometry. So what would I do? You could either delay the surgery, and the patient's disappointed and inconvenienced. You can say, okay, well, I can't really tell how much astigmatism you have, so I'm not going to recommend a premium lens or a toric because I can't tell you how much astigmatism you have and what the orientation is. So the patient's now disappointed if they want a premium lens. Or, we've all succumbed to, it's probably okay, it's good enough, and I'm going to put in a toric lens, and you don't get the result that you intended. And then the patient and you may be very unhappy with the results. So what we started doing before 7.0 was basically setting up an extra appointment. The patients would come in, they would have mybography done as part of their cataract evaluation, and an iTrace to look at the DLI to basically see if they really need surgery, especially if their corrected visual acuity is good. And then we gave them what we call dry eye homework. Again, this was based on something that Warren Hill does. He has all their patients do lid hygiene, a heated mask, and lubrication twice a day for 2 weeks. And if they're meibomian glands, if they're not expressing good meibum, or they have really bad glands on mybography, then we're recommending thermal pulsation and waiting 3 to 6 weeks. But there's a problem, and then they would come back, and they would have a follow-up appointment, which we called a dry eye pre-surgery appointment. They would have any point of care testing like tear film osmolarity and inflammatory, a repeat iTrace and their first set of biometry, a slit lamp exam, and then if everything looks good, now I've got 2 iTraces now in the system, one when they came in for their cataract evaluation, and now one mainly using it to look at the surface of the cornea. And if those 2 visits within a few weeks apart, if the topography matches and there's not a large standard deviation in the biometry, and the glands look okay based on the slit lamp exam, no staining, no lissamine green staining, then the patient is said, okay, you're now cleared for surgery, you don't have dry eye, here's your information about lens options, go home and think about it, and then they come back for their pre-op measurement where they have their final they'll make their lens choice, they'll have a MAC OCT, and their final iTrace and biometry, and finalizing their lens implant choices. And this is an extra visit that we do that a lot of other practices don't. And it has advantages and disadvantages. The advantages are the patient has more time to rehab their surface, increasing the likelihood of them being a candidate for premium lens, and they have more time to think about their lens options. The disadvantages are there's a longer lead time to surgery. Patients are like, why do they have to come in and have an extra visit when they can go somewhere else and basically to be told they have a cataract schedule or pre-op and schedule surgery? The extra visit is difficult for some patients. They have to get a family member to bring them, transportation, mobility, distance from the office, all of that stuff. And we don't, in the United States, we don't get reimbursed for topography for a cataract. You can only get reimbursed for biometry once. So we're performing these extra tests multiple times, which crowds the schedule and takes a lot of tech time. And the advantage of more time to think about the IOL options is also a disadvantage. So we thought about this and we said, how can we eliminate this extra dry eye visit without decreasing premium conversions? So now with 7.0, we have the ability, we do the iTrace on an initial cataract screening, including the tear film index. We evaluate the results. If the exam result screen shows green, that the corneal surface is green, then we skip that extra visit. We no longer need it. We know, based on the iTrace, that the patient can proceed to pre-op. We still do the dry eye pre-treatment, so they won't come back for their pre-op for 2 weeks, but I know that there's a really good chance if their corneal surface was green when they haven't done anything at all, that they're gonna stay, that the corneal surface is gonna stay pristine for their pre-op, and there won't be that conundrum of, can I still offer them a premium or not? If it's yellow or red, or they have a poor TFI, then we would still have that extra visit. So, because we know they need it, and there's a chance that when they come back that the surface still won't be good, and we're gonna have to do other things, like thermal pulsation, immunomodulators, Restasis, Xiidra, Sequa, any of those. And then they'll still have that interim follow-up appointment prior to scheduling surgery. And here is just an example of two eyes of two patients. Clearly this patient has a DLI of 2.1, a significant nuclear sclerotic cataract. I actually saw this patient back just this week, and her surface has finally improved, but clearly she's got a red lens, so we know that her lens is contributing to her vision, but she also has a red corneal surface, and if you look at her tear film index of 1.3, I mean, the tear film index is great, but sorry, iTrace guys, you don't need it when you've got these Meyers that look like that. They're pretty gnarly right there. So this patient was instructed. This patient actually took a number of visits before we could actually get her surface to the point with steroids and otherwise. And here's an example of just another patient who has a red exam result screen. So it's clearly the lens is the cause of her visual dysfunction, and the corneal surface was green. We actually didn't even do a tear film analysis, tear film index, because her surface was green, although now we've transitioned into doing that on all of our evaluations. So that's all I have to say. Thank you very much. We do medical missions. That's me and my daughter in Honduras. And if you have questions, there's my email, but really it's Sonia for those of us in the US. So thank you for your time. Thanks.